across the nation, as well as in mobile stroke units. Additionally, there is going to be nationwide reimbursement for virtual clinical assessments of end-stage renal disease, and will add individual dialysis facilities in the patient's home as valid locations. Next up, effective January 1st, 2020, and this is currently open for public comment until the end of next month. Medicare Advantage plans will soon have the flexibility to add telehealth services as core benefits. And it's really going to be flexible as to what the plan would like to see. Additionally, ACOs will have the flexibility to use telehealth in non-rural areas and the patient's home. Some other acts that have been proposed before I get to the CMS payment rules include the VETS Act. This went into effect June of this year and is specific to the VA. However, it has created a single license so that VA licensed clinicians can provide telehealth across state lines into patients' home. Again, that is specific to the VA population only. Another act that is in the process of being passed likely January 1st of next year is the Support Act. This is the opioid bill that we've been hearing a lot about. It expands the use of telehealth for substance use disorders and co-occurring mental health disorders and adds the patient's home as an eligible site. What is also interesting about the Support Act is that it is placing a one-year deadline on the DEA to create the special telemedicine registration for prescribers, which would eliminate the need for that initial face-to-face encounter. We've been waiting about a decade for this special telemedicine registration, so hopefully with the passage of the Support Act, that will come to fruition. There are a few other bills that are in early stages right now, one being the RUSH Act, which has to do with on-site acute care in a skilled nursing facility via telehealth. There are two bills, the Mommies Act and the Rural Moms Act, that are putting the onus on states to adopt more favorable policies for the use of telehealth in maternal fetal medicine. And there is a bill out there right now, HR 7083, which is the Genetic Counseling Services Act of 2018, which will allow for greater reimbursement outside of rural areas for genetic counseling services provided via telehealth. So to get to the meat and potatoes of what I wanted to talk about, which is the specific CPT codes that CMS has put forth for their 2019 payment rules and fee schedule. Keep in mind these codes are not subject to 1834M restrictions, which are the current restrictions on rurality for telehealth billing and Medicare. These codes would not be subject to that. So the first one is G2012, and that's called Brief Communication Technology-Based Service. So this is your synchronous real-time virtual check-in. It is a patient-initiated visit and it has to be with an established patient. It can be done via telephone or a two-way audio interaction enhanced with video, so you're video conferencing. The reimbursement for G2012 is going to be $15 per visit, and it's a 5 to 10 minute check-in, so they did put a time frame on this. The catch with this one is that this particular real-time check-in cannot originate from an E&M visit 7 days prior. So we're thinking this may be beneficial like in post-acute consults for PCPs and specialists, but it has to be at least 7 days after a prior E&M visit. Additionally, G2010, remote evaluation. This is your asynchronous or store and forward code. Again, it is patient-initiated with an established patient, pre-recorded patient-generated video and or images, and is reimbursed at $13 a visit. Follow-up from the provider side can be done anyway, even if it's a text or patient portal usage. And lastly, we have codes 99446 to 99449 and 99451 and 99452. These are interprofessional consultations, your provider-to-provider consults. These can be billed at a rate depending on the code and time frame of anywhere from as little as $18 to being reimbursed up to $73 per consult. These can be done through EHR, internet, or telephone. Moving on to remote patient monitoring, there are several new codes that have been proposed that allow both the professional and technical components to be billed together. And these new codes do not require an in-person visit. So the first one is 99457. This is the collection and interpretation of data that is 20 minutes or more per month, requiring interactive communication with the patient by a physician, qualifying healthcare professional, or other clinical staff. So they have opened it up to other clinical staff, meaning a nurse could collect and interpret data and get reimbursed for that. The reimbursement rate for 99457 is $52. Next up, or I'm sorry, 99457 is $52. Next code is 99453. This is the code that you can bill for the initial setup of technology and patient education, so the technical component. When you're in a patient's home, showing them how to use a tablet, how to get it set up, customizing whatever metrics you want on the tablet, etc. This can be billed at a rate of $19 a session. And lastly, code 99454 is device supply with daily recordings, programmed alerts, transmission on a monthly basis. This is also the technical component, and this is reimbursed at a rate of $64. So lots of wonderful changes, I think, happening on the CMS side of things. Additionally, there is going to be some guidance for FQHCs and rural health centers from CMS. One of those is that the face-to-face requirement is waived, allows billing for virtual check-ins and remote evaluation of store and forward visits. So those G codes that I was referencing previously, FQHCs, will be able to bill. The code for FQHCs is G0071. The patient must have a minimum of 5 minutes of virtual care and be seen at least once in the prior year face-to-face. So they seem to be waiving some of those requirements and restrictions for FQHCs as well. The only downside is the Interprofessional Consultation code that I had described previously, the 99446 and 449, is not going to be available for FQHCs. And then there's one additional telehealth code for prolonged preventive services. This is subject to rurality restrictions, hence why I've chosen to wait to talk about it. It's an HCPCS code of G0513 and G0514. Those are both reimbursed at a rate of $66, and it's prolonged preventive services. So this is a big turning point. Lawmakers seem to be very supportive of telehealth, but I can still see concerns about cost and program integrity. And these changes will be incremental over time, but these payment models improve economic and business models and allow programs to start or expand their telehealth services. So the message I'm hearing is that, lawmakers are supportive and healthcare systems should start taking advantage of these new codes when they become available January 1st of next year. So I'll pause for a second and go over any questions. And of course, without saying, I always send out notes after these calls. So yes, you will have all of this written out for you in the meeting notes after the call, so no worries there. I'll check to see if anybody, I'm just going to stop sharing my screen now. So I'm going to just check and see who's got an audio question. Just give me 1 second. Okay, so I'm going to start opening some lines. Dr. Corigliano, I'm going to open your line for your question. Go ahead and ask.
Yeah, hi, this is Dr. Grigliano down in New York City. And some of the questions were about the interpersonal consultations, how exactly those are billed. Is that billed by the providing psychologist who's giving the consultation, or is that billed by the facility?
You know, the information I've gotten so far does not specifically state. This is a kind of high-level overview, so I can dig a little deeper and find out. My guess is that the provider that's providing the consultation would bill for the service.
Okay, great. Thank you.
But I will add that to the list to look up for you.
Mm-hmm.
All right, thank you. And next up, I'm going to unmute your line, Felicia Parker. Go ahead and ask your question. Felicia, your line is open.
Oh, I'm sorry. Did I press something? I didn't have a question.
Oh, yep. There was a question mark next to your name, so never mind. Thank you.
Oh.
Okay. And let me see here. If anybody else had raised a hand. All right, it doesn't look like there's any more questions, so I am going to open up the line now to Megan Program, who is from DOH and is going to just give us a brief overview of the regulation changes that are coming from DOH, and you have the ability to share your screen, Megan, whenever you're ready. I'm going to unmute your line now.
Okay, thanks everyone. This is Megan Procorum. I'm with the Office of Primary Care and Health Systems Management, and I work closely with my colleagues in the Office of Health Insurance Programs. Today I'll just talk briefly about our most recent statutory changes to telehealth parity law, which affect Public Health Law Article 29G. There were recent amendments as part of the enacted 2018 budget, and that added some expansion of additional interactive communications for remote patient monitoring and our definition for remote patient monitoring for the Medicaid program. And so basically that allows different types of modalities to be allowed for reimbursement under remote patient monitoring, and it includes things like the patient filling out an interactive query form, or even a cover of a telephone call based on the transmission of patient health information to a provider at a distant site. And just to kind of recap, under the Medicaid program, remote patient monitoring has to be prescribed by a physician or a nurse practitioner or a midwife, and a registered nurse can act as the a telehealth provider to receive the remote patient monitoring data. Other changes expanded the list of telehealth providers eligible for Medicaid reimbursement. And so the ones that were recently added include CASACs and their credentialed alcoholism and substance abuse counselors certified by our Office of Alcohol Abuse and Substance Abuse Services, and then also the Early Intervention Program providers and service coordinators. And so the department's Early Intervention Program will be issuing specific policy and guidance for reimbursement based on that statutory change. And then also under our new eligible telehealth providers, are clinics licensed or certified under Article 16 of mental health law, and also certified and non-certified day and residential programs funded or operated by Office for People with Developmental Disabilities. There was some additional clarification in the statutory language for hospitals licensed under Article 28 of Public Health Law. These have always included Article 28 residential healthcare facilities, which are nursing homes, but language was added that residential healthcare facilities that serve special populations are also reimbursable telehealth providers under Medicaid. And I just want to note that in general, all telehealth practitioners still must be licensed and registered with New York State Medicaid and act within their scope of practice. Now, there was an exciting expansion to what is defined as an originating site under New York State Medicaid. So now a patient may also be located at a certified and non-certified day residential program funded or operated by the Office for People with Developmental Disabilities. And then a patient may also be in their place of residence in New York State or other temporary location in or out of state for all three telehealth modalities. So prior to this enacted budget year, a patient may only have been located at home and receiving telehealth service through remote patient monitoring, but now it can include telemedicine, which is that live video conference. So that's very exciting. Also part of the budget bill was that the department and our sister agencies would issue a single interagency telehealth guidance document. So we've been working, the Department of Health, Office of Mental Health, Office of Alcoholism and Substance Abuse Services, and Office for People with Developmental Disabilities. We've been really working together since telehealth parity law came into effect. But we have heard a lot of feedback that things get really confusing, especially providers working across the jurisdictions of the different agencies. So we are currently working on that guidance. And as a little bit of a preview, it'll go over the different recognized telehealth modalities across the agencies. So as I was mentioning, for the Medicaid program, telemedicine, store and forward technology, and remote patient monitoring are the three modalities that are defined in statute for Medicaid reimbursement. And then Office of Mental Health currently uses the term telepsychiatry, and OASAS currently uses the term telepractice, and their legal definitions closely align with the public health law definition for telemedicine, which is that interactive live video conference between the provider and the patient or the client. And then for Office for People with Developmental Disabilities, they are recognizing the same modalities as what's in public health law under Medicaid. And then in terms of regulations for facilities that are licensed under the Department of Health exclusively, there are currently no regulations specific to telehealth, but all other regulations and then federal and state laws that would normally apply for that service if it were conducted face-to-face would still be in effect. But we really consider telehealth to be a mode to deliver a service rather than a regulated service in and of itself, whereas for OMH, OASAS, and OPWDD, there are regulations that allow for their services to be delivered via telehealth, and then OMH and OASAS have regulations specific to telehealth, and OPWDD will be, they're currently drafting administrative memo for service providers. And then just to go on quickly about whether or not a provider needs approval from an agency to deliver a service via telehealth, for the Department of Health and for Office for People with Developmental Disabilities, if you're strictly only providing a service that falls under the purview of the Department of Health or OPWDD, you do not need approval specific or prior to delivering a service via telehealth. Whereas for Office of Mental Health and OASAS, so if you have a unit within your facility or a program that OMH or OASAS regulates, you do need agency approval to provide telehealth. And then our guidance document will speak to reimbursement. We are awaiting the release of a special article Medicaid update that will really talk about the expansion of telehealth reimbursement for the Medicaid fee-for-service and Medicaid managed care covers insurers, and that, we're hoping that it's released very soon, and that will provide some detailed instructions on what modifiers to use and different scenarios for Department of Health licensed facilities, Article 28 facilities, and private practitioners. And then our guidance document will talk about the differences in reimbursement between the agencies. So we will have separate guidance specific to DOH licensed providers and private practitioners, and then OMH, OASIS, and OPWDD have different restrictions based on reimbursement, where the originating site or the program or facility where the patient is enrolled is the one who bills for reimbursement through Medicaid, and they have to be a Medicaid provider in good standing. And that's about it for the high-level changes on what we covered at our conference.
Thank you, Megan. I apologize because I know this question gets asked a lot, but do you have any sort of expected time frame on when we might see these documents?
Well, I do hope it's soon. It was approaching its final stages of approval, so hopefully within the next month, but I don't really have any specific timeline at this time.
Okay. And, rest assured that everyone on the line will get some sort of communication from myself once Megan makes me aware that that article has been published or that guidance document is available. I don't see any other questions that have come through specific to your regulations, Megan, so thank you very much for the update.
Thanks.
And next up, OMH, I do see Amy Smith on the line. Amy, if you just wanted to provide the group with a brief update about what you spoke about at the telehealth conference, about the Part 596 regulations.
Sure, Katie. Thanks for having me on. So we just wanted to provide an update. We're changing the title of Part 596 from telepsychiatry to telemental health, just to be more reflective of what will be authorized under Regulation Part 596. We'll be expanding the practitioner types beyond psychiatrists and psychiatric nurse practitioners to include licensed psychologists, licensed social workers, and licensed mental health counselors. We will now be including the ACT and PROS programs as eligible treatment settings, and we do have some specific guidelines and conditions outlined within the regulation. We'll be expanding the hub or distance site beyond just New York State Medicaid enrolled location to now include home offices and private practices. And for psychiatrists and psychiatric nurse practitioners, their location can be anywhere within the U.S. And for the other practitioners, they can be located anywhere within the state of New York. We're also expanding the spoke or originating site. So as Megan mentioned, with the change to public health law, we've now identified that site to be anywhere the client is located within New York State or another temporary location within or outside of New York State. And we're also exploring to look at the various mobile technologies that will now be allowed. And we have kind of stepped away from the requirement for pan-tilt Zoom, but we will have it as a strong recommendation within our guidance. And, just as a highlight, these are proposed changes. We're expecting them to go forward for public comment any day now, but they are still, as it stands, just draft and proposed regulation changes. But those are the highlights.
Excellent. I do have a couple of questions. The first one, let's see. I'd rather this person ask the questions. I'm not entirely sure. So Aurelia Baracco, I've unmuted your line if you'd like to ask your question.
Hi, we're just wondering for place of service, or if home is an acceptable place of service for some services to be performed, does it still apply specifically to home codes, to home health codes? Or if, you know, like you mentioned, a place of service home is being acceptable if they wanted to bill a 99213 place of service home, is that appropriate? We just need a little clarification on what can be billed from place of service home.
I'm not sure if I can answer that specific to OMH. I mean, for our licensed providers, it would still be the same billing codes for individual therapy, med management, and things like that. Katie, I don't know if you would add anything else, or?
To my knowledge, if the home is an acceptable place of service, we would have to wait and see what comes out from obviously DOH and OMH. I don't know if you're asking this specific to Medicare and what I spoke about.
Yes, this is for Medicare.
Okay, yeah, so that helps to clarify that a little bit. The G2012, the synchronous real-time virtual check-in code, indicates that the patient is in their home. So I don't believe you would bill that in addition to an E&M code. I believe this code is specific to that type of service.
Okay, so with the place of service home acceptable, it's still restricted by the codes that you could bill in that place of service.
I'm not really following your question. I do apologize, but as I understand it, for Medicare, which is irrespective of DOH and OMH, that you would bill G2012 for that quick check-in, that 5-10 minute check-in with an established patient. The patient initiates the visit, and I imagine that you would bill that with the place of service code of 02, which indicates that telehealth was used. There hasn't been any other language around whether or not there's a place of service code for the home that has to be used.
Except for this consult. So only for this consult will home be acceptable. I guess we're just trying to understand if they're using this as a consult and they have to have 5 to 10 minutes and this is for check-in, once they provide the actual service, what code would they be utilizing?
The G2012.
Only that.
And then for the other approved Medicare telehealth codes, how many of those are acceptable for the patient to be in a home setting?
I believe that for the G2012 and 2010, the synchronous and asynchronous, that can be initiated from the patient's home. And then obviously the RPM codes that I spoke about would be in the patient's home.
Okay.
The interprofessional consult is the only one that would not be in the home.
Okay.
Yeah, I hope that helps. Again, I still have to do some digging into a 2,300-page document. So there may be more information that I come up with. This is just a high-level overview. There are a couple of questions from folks, too, about GT modifier or no GT modifier. Back in January, CMS did away with the GT modifier, and they have moved to the place of service code of 02 to indicate that telehealth was used. That does not mean that other commercial plans or our state Medicaid don't still use the GT modifier. As Megan talked about, the GT modifier is still used for New York State Medicaid.
Yeah, can everyone hear me? This is Megan again. The updated telehealth article will speak to what exact modifiers to use. And in general, the change that will happen is that New York State Medicaid will try to align itself with Medicare. So the 02 modifier will begin to be used. And then the 95 won't necessarily go away. It will depend on the type of CPT code used. So again, that'll all be in our special telehealth article.
Thank
so
you.
There'll be a GT and a 95, and when you can't use the 95, you'll use the GT, and then you'll use the O2 as well.
And then, Amy, a question for you came in. Originally, OMH said screens or monitors had to be of a certain size in addition to using the pan-tilt zoom camera. Will this language be disappearing?
Yeah, we'll have to modify that probably significantly based on the changes and the different types of devices that will be used. So, yep.
Okay. And then one more question that came in that I'm just going to unmute this person's line and let them ask it. 1 second. Nissan Friedman, you need to put in your audio pin, and I'd like you to ask your question about mobile units. We'll just give him a second to do that. There was a question that came through, just getting back to Medicare real quick, with whether or not copays will apply for the new Medicare virtual check-in and interprofessional consults. I do not know the answer to that. That has not been discussed in any webinars or articles I've seen yet. So more to come on whether or not copays would apply for those particular G codes. And this person has not put in their audio pin, and I'm not sure if this is a question for myself, OMH, or DOH, Nissan, but I'm going to ask it of the group. Is a mobile unit included as a place of service? I'm not sure what this person means by a mobile unit. I know that in the Bipartisan Budget Act, there is language in there for mobile stroke units, which would be an allowable place of service, but outside of that, I don't know. So more to come on that, I guess. And there is another question for you, Megan, that this person thought they heard you say there is a crosswalk code for G2012 of G0071. Is there also a crosswalk code for G2010? I don't know if that's a question you can answer, Megan, because I spoke about that, so maybe this person's a little confused for FQHCs. I don't know if you have any information on that. But I'm guessing not. So, Terry, you'll need to follow up with me offline because I'm not exactly sure what you're asking. A lot of these questions that are coming in, we still have to do some due diligence on what exactly these codes are going to look like in terms of copays, crosswalks, things of that nature. So just kind of bear with me. It's, again, a 2,300 plus page document. It's a lot of work to get through it. There was a question on copay requirements for remote patient monitoring. Again, we have not seen any information on copay requirements for remote patient monitoring with CMS and Medicare. So if I find information, I'll communicate it to you. And then one more question for, I believe, Megan. Can we assume that for New York Medicaid reimbursement, the provider can be located out of state so long as they have a New York State license and are enrolled in New York State Medicaid?
Yes, that is correct. As long as they have a New York State license, they can be located outside of the state.
All right, thank you. And looks like there are a few other questions that have come through about CMS. Again, I'm not going to answer all of these on the line because I still have a lot of work to do in pouring through these regulations, and the questions that are being asked are extremely specific, and we will not have answers on those right now until we see the final fee schedule as well as billing and things of that nature. So just stay tuned. This was just meant to be an overview today. There are a lot of webinars coming out from different vendors that are talking about this, as well as myself trying to pour through these regulations with the very limited amount of time I do have. So I will definitely get back with everyone who asked a question today. Next up, of course, in the interest of time, is a brief overview from OASAS. Unfortunately, Sarah Osborne was not able to be on the line today. She is retiring at the end of the year, so Carmelita Cruz will be taking over as a participant in these meetings, but was unable to be on the line today because of the holiday week. So what I'm going to do is share my screen, and I'm going to share with you the presentation that Sarah gave at the Telehealth conference regarding the OASAS regulation. So hopefully everyone can see my screen here. OASAS created Telepractice Regulations effective January 24th of this year. The regulation is accompanied by a standards guidance document, which was recently updated on August 20th. And some of the updates in there, especially as it relates to technology, have really, I think, loosened some of the restrictions on technological requirements, which OMH has also done. So basic provisions of Part 830, these are the Telepractice Regulations, include information on provider designation, service limitations, the policies and procedures required for attestation, different types of allowable practitioners, and patient-informed consent. So certified providers can apply to the Bureau for designation by submitting a plan and attestation, which needs to include possible sites for locations of both the patient and practitioner, any additional locations, contracts or agreements with practitioners if appropriate, the types of services you intend to deliver, and how you plan to ensure confidentiality and patient rights. There are some limitations to telepractice. It does not include an audio or video telephone conversation, email, or fax transmission. While those communications may support telepractice, it is meant to be that two-way live audio-video transmission. Telepractice can be used to deliver admission assessments, direct transfers, mental health consults and psychosocial evaluations, medication-assisted treatment prescribing and monitoring, and other services as approved. The type of authorized practitioners for telepractice are physicians, physician assistants, and nurse practitioners. Additionally, clinical staff such as KSACs, credentialed or approved by the office and acting within their scope of practice, can also provide telepractice services. Peer advocates and student interns do not qualify for this. Site approval. So the distance site, aka the hub site where the provider is delivering the service, can be located anywhere in the U.S., but they must be licensed to practice in New York State and Medicaid enrolled. Where the patient is located is in any site approved by the office as proposed in the plan and attestation for designation. So that's going to be on a case-by-case basis as to what you submit, what you're thinking of, where the spoke site will be. Patient rights, patients or prospective patients, of course, must consent to receiving services via telepractice. I would recommend that to anyone, respective of agency or payer, that you obtain consent. Patients must be evaluated for suitability prior to a telepractice session. Patients may be accompanied by a staff member. They don't have to be. And then there, of course, are additional federal rules that apply to the administration of buprenorphine. So medication-assisted treatment, there were a few questions that came in earlier. The practitioner must follow standards of professional practice regarding establishing an appropriate clinical relationship. The practitioner, if a prescribing professional, may issue a prescription if it is determined to be medically appropriate, and the practitioner must verify that the patient has been determined to be appropriate for services delivered by a telepractice. Of course, with buprenorphine, the practitioner must conduct an in-person evaluation first, or they can do a telepractice evaluation with another DEA-registered provider who is physically present with the patient, or conduct a telepractice evaluation with the patient located in a facility registered with the DEA, the hospital or clinic. The induction itself must be in person, obviously. For reimbursement of telepractice services under OASAS, services are considered face-to-face. The provider is always the billing entity. Practitioners are reimbursed for services by provider via contract or MOU. Long-term counseling is not an approved OASAS service without a waiver unless it is an emergency service. And billing codes are the same as any other service. And as Megan spoke about earlier, DOH is expected to issue Medicaid billing guidance in the coming months. And if you have any additional questions, these are the emails to direct them to. These individuals were not on the line today, so I don't want to speak on their behalf with any questions as it relates to the material. If you don't want to filter your questions directly to them, you can send them to me and I can have that conversation. So I'm just going to stop sharing my screen quick and get to the final part of our discussion today, which is around some updates from the North Country Telehealth Partnership. So as we move into 2019, the last 3 telehealth learning collaboratives have been maxing out attendance-wise. So we currently, as you know, use a GoToWebinar format, and our license only allows us 100 attendees, and we have been maxing out, and not everybody is able to access the learning collaborative in real time, which we obviously don't want anybody to be kicked out or unable to listen to the content. So starting in January, we will be moving to Cisco WebEx, and this will be hosted by the Department of Health. Megan and her team have been kind enough to offer us one of their WebEx, like the use of their WebEx platform so that we can have up to 500 attendees if we had that much interest. So you will be seeing a link come from me in the coming weeks with a new registration. So going forward in January, we will not be using GoToWebinar anymore, and we will be using Cisco WebEx hosted through the Department of Health. The next webinar is going to be on January 14th at 2 p.m. That is a Monday. It's the second Monday of the month because the third Monday is a holiday, and we want to make sure that everybody is actually in the office that day and not schedule it for a holiday. We are looking for a speaker for January, so please reach out to me. My email is kcook@ahihealth.org, and I will get with you privately offline if you have an interest in speaking on the collaborative. We really try to look for speakers who can talk about programs they've implemented and discuss some of their successes and challenges in doing so. Speakers who have implemented best practice programs and are seeing great success, or are maybe a subject matter expert in billing or credentialing or telehealth in general. So if you feel that you fit that bill, then absolutely reach out to me and we'll connect. Have a wonderful Thanksgiving and Christmas, and we will connect again in January on the 14th, and stay tuned for that invite for the WebEx. Thank you.